Good afternoon. The part of my talk, I've been using MicroPulse now for probably 6 to 8 months, so I'm going to talk more on the realistic side of if you buy this laser, if you have this laser and you're going to start to use it in retina, what to expect and what sorts of patients that you should recruit when you first get going. We definitely live in an anti-VEGF age. I'm from America now, and I will be honest with you, fellows that I train and doctors that I work with, their first shot that they do is actually putting a shot of Avastin, Lucentis, Eylea in someone's eye. And these have really been well documented in Rise and Ride. But the truth is that patients, one, don't like shots every month, and two, these drugs are really efficacious in only about 30 to 35% of all patients. So a third of patients do really, really well, which leaves you with the option of what do you do with the other 2/3 of patients, or what do you do with patients that aren't responding well or don't want shots at all. The DRCR actually demonstrated that if you use laser in combination with anti-VEGFs or even steroids, and I use all modalities, that the laser is still beneficial. And truthfully, I think in today's day and age, laser is well alive and is still a very viable part of your treatment option when looking at diabetics or vein occlusions. My interest in MicroPulse is truthfully looking at patients either as a first-line treatment for those that don't want treatment with a shot in the eye, and for patients that are really not responsive. I am very underwhelmed at the benefit of anti-VEGFs in patients that have diabetics. Some of my vein occlusions respond very well to anti-VEGFs, and some of them don't respond at all. And those are the ones that really require looking at for laser. The other thing is that this laser is really almost a 4-in-1 or 3-in-1 type of laser, which is very appealing to me. One is that there's an indirect laser as well to treat tears and peripheral detachments. Two is that you also have the continuous wave if you want to do basic focal laser, and the MicroPulse. And then also there is the pattern laser for peripheral laser photocoagulation. So I look at this as really a complete laser that was very, very practical for our practice to purchase. I think when you get into MicroPulse, the concern is that we've all been trained, those of you that are in retina, to look for a blanch or a photocoagulation spot. And so when you do the MicroPulse for the first time, there's this sort of leap of faith that, am I going to be treating something and getting this large burn? You're not going to get that. And so I think there's a bit of a leap that when you start this, you sort of have to trust the laser. And then once you get into it, there's a true comfort factor that when you realize what this laser can do. From my consideration of starting MicroPulse, obviously, is safety. This is, Estella showed you can treat the fovea. And obviously, I think no one who starts off in this laser is going to want to go and shoot the fovea right away. There's a comfort factor. But this is a safe laser. It's been shown in many studies in the retina to be efficacious. And to be honest with you, it's much faster and more efficient than doing focal laser to microaneurysms. I can really only speak from economics in the United States that we get paid for laser and that we do it, and we probably get paid better for laser than we do for injections, but that's not the reason that I do it. But from an economical standpoint, we do get reimbursed in the United States. When you start off with MicroPulse, I think the first thing you need to do is probably find patients that you're not going to be treating the fovea, because you're not going to really want to jump in and shoot the center of someone's vision. And so I would look for a straightforward patient where the area of CSME is outside the fovea, and you can treat it and get an idea of what this laser does. And are there going to be burns? Are there not going to be burns? Are the patients going to notice it? So I would definitely recommend choosing a few patients that have a more mild form of disease, and then from there you'll gain trust in the laser and you can move right along. The patients that I treat with MicroPulse are those that do not respond to anti-VEGF for DME, which is a number of them, as well as branch vein occlusions. I have a number of patients that don't want any injections at all. When you tell them that they're going to get shots in the eye for the next 6 or 12 months, they look at you like you're crazy. And then there are some patients that have very limited macular edema right around the fovea, that it's probably too small of an area to start off with injections. And in that situation, the risk of the injection is probably too great. And in this situation where you have a non-burning laser, those are excellent candidates to start off with. And the other thing is I have adopted a number of patients in my practice over time who have a lot of heavy laser burns. And if I'm going to do more laser, I don't want to cause any more destruction to the laser to the retina than what's already there. This is a patient that I treated about 2 weeks ago, and I picked this patient because she's darkly pigmented, and I wanted to show to you all that there is no damage to the retina within 15 minutes of treating. So this is the color photograph. I don't know whether there's actually 3 small areas of CSME. One is there, one is right here, and one is there as well. And some of the exudate is leaking to the fovea. And then there's an autofluorescence picture to the far left, and that's just comparison of pre and post laser. So I did a 7x7 grid to here, here, and here. So right in this area. And then you can see 15 minutes later that there's no visible burns to this area or that you can see on fundus autofluorescence. So I've become very comfortable with this and really trust the laser that what you are told that it's going to do is actually what it's going to do, that it's not going to leave a burn to the patient's retina. Now, I have the Tech Cell guided micropulse, which means that when I turn the laser on and I start to use it, I'm going to see a grid, and that grid is what I use to guide my treatment. Now, the one thing that I will tell you is that for those of you that use a Pascal type laser, this is a little bit of a slower laser. And so I really tell my patients to focus in on a point either behind me or at my ear, because if they start to move, the one negative I will tell you is that they can lose, once they move, is you can lose sort of the where you've treated already. And so I have patients really focus into my ear. Once they do that and they don't move at all, it's really easy. And I just, hit them with multiple laser grids in that area. So you'll be able to see the 7x7 block in this Tech Cell guided micropulse. And it's really excellent as far as guiding and knowing exactly where you're going to hit them with the laser. This is a very good study by Levinsky that was published, and I would garner to say that if you put down a wager and said which of these 3 groups, modified ETDRS, micropulse high density, or micropulse low density, you would probably think that the micropulse low density would come out on top. It doesn't. Basically, this shows that when you use high density, low intensity laser burns, they actually do better than low density and standard ETDRS. And those patients had actually greater reduction in thickness and greater improvement in visual acuity. Hence the need to use this high density laser. This is basically just a schematic showing you, and I think the most important part is here, when you're doing a high density laser, you're actually painting the whole area. There's no longer small spots. And this is really in contrast to basic ETDRS or PRP laser, where you get a heavy, heavy laser burn, which is what Rob was talking about, and that that retina is no longer functioning. So you're looking to gently raise the temperature of the RPE for the effect of the burn. Now, these are the settings that I use, a little bit different than Stella's. I use a 200 micron spot size, which I adjust on the slit lamp, 200 millisecond spot time, 400 milliwatt power. One of my partners does dial down the power a little bit to around 300 or 320, but I use 400. These are very standard settings. I use a 5% duty cycle. And then down here, this is another window that you'll see on the laser. I use a 7x7 grid with 0 degree spacing. So when you turn this on, there'll be a dial down below on the machine, and you have to turn that down to 0 degree spacing, and that will allow you to paint the retina in that area. I am not a big user of fluorescent angiography, but for this type of treatment, I definitely do it, and I use it to guide my treatment to the area of leakage. And so I will do the fluorescein, go back to the patient, and then do the laser. A lot of times in just standard focal ETDRS basic laser, I oftentimes just visualize where I'm going to treat, but for this, I definitely use angiography. I've got about 3 cases, and then I'll wrap this up. This is a patient who had never had treatment before. preoperative visual acuity is 20/50. You can see the thickness up here on this area on the OCT map. And then 2 months later, you can see that there is a reduction in the thickness. It's not completely gone, but it's definitely trending to improvement. And the visual acuity is better. Second case, this is a more chronic patient, much thicker diabetic macular edema, preoperative or pre-laser visual acuity 20/60. And you can see 2 months post-laser, the vision's improved to 20/40, and there is a reduction in the amount of fluid. And finally, this is a more chronic case. This is a patient who had had multiple injections of Lucentis. They were treated in an outside office from our Tufts University office. And you can see on fundus autofluorescence, these are the previous laser scars. And predominantly subretinal fluid. The patient was treated 6 weeks post-treatment. You can see that there's no additional laser scars. There's still some intraretinal fluid, but the subretinal fluid has reduced. So this has actually been, from my standpoint, a big welcome addition to our laser at Tufts. I think from my standpoint, and I'm a retina specialist who operates, this is a real multifunctional laser. It's not just a Pascal, and then I've got to go somewhere else to get an indirect. You've got the indirect, the continuous wave, and you've got the MicroPulse. And I've grown very fond of the MicroPulse, and really it's my go-to laser now for treating diabetic macular edema. I think it's excellent when you're treating fellows and residents because it's a very safe laser. You know, I've used it enough now that I have complete confidence that you are not going to have a visible burn or cause damage to the retina. And as far as treating patients with diabetic macular edema or venous occlusive disease, I'm of the philosophy that you have to, it's a multimodality treatment approach. And I think that MicroPulse really fits into this. And as far as in our group of 6 retina specialists, it's becoming more and more accepted. I think we've talked about most of this. There's really no tissue damage that's present. Patients accept it a lot. They're obviously not getting a shot in the eye. They're very comfortable. It's a very quick procedure, and I think it can be used either first line or in conjunction with anti-VEGF injections or steroid injections. And in conclusion, you know, this is a fovea-friendly treatment. You can treat the fovea without expecting any damage. I think Stella's group and others have shown in many of the publications that this is an efficacious treatment and definitely can be used in combination, you know, given the DRCR net findings. Thank you very much.